the next section that we're going to talk about is the thyroid gland. This is a common area where test questions come from. So we'll talk extensively about mechanisms of actions and tests to do. The first thing I want to talk to you a little bit about general aspects of the thyroid. So here's the thyroid right here. This is what happens in the thyroid. You basically uptake all the iodine in the body, maybe about 96-97%, and you make thyroid hormones out of that, and the main secretory product of the thyroid is T4. So the main hormone that you make from the thyroid is T4, and then in the periphery, right here, somewhere in the periphery, this gets converted mostly to T3. T3 is more potent. T3 is more potent. There's a better effect on the tissues from T3. So basically, the thyroid secretes mostly T4, and then you get T3 conversion in the periphery, in the tissue where you have all the metabolic effects, and T3 is more potent. Now, you're going to see here that it's right here that when you secrete endogenous T3 and T4, we said mostly it's T4, but there's some T3 excreted too. You co-secrete it along with this thing called thyroid binding globulin. This is very important. It's a very important test that we do sometimes to see if the thyroid hormones are endogenous or not. So thyroid binding globulin. It's a very important test. It tells me that all these thyroid hormones are endogenous. Now, if you look at here a little bit on this chart here, you'll notice also that there's a feedback from T3, T4 back to TSH, right? So the hormones that get regulated is the feedback loop back to the pituitary is through TSH, and then at even higher level, hypothalamic thyroid releasing hormone, all the way up here. So the main secretory product of the thyroid is T4. It gets co-secreted with thyroid binding globulin. Most of this becomes T3 in the periphery. It has all the metabolic effects, and these both hormones, but mainly T3 because it's more potent, has the feedback loop back to the pituitary with TSH and back to the hypothalamus with thyroid releasing hormone. Now when we measure thyroid hormones in the periphery, we like to measure only free hormones because only the free hormones have the metabolic effects. So out of the total T4, only 0.01% is free. So let me say this again. Out of the total T4, only 0.01%, even less than that, is free T4, but that's the one that has the metabolic effects on the body. And the same thing with T3. 99.99% is protein bound. Albumin and stuff like that bind that. So it's very, very important that you understand that when you measure thyroid hormones in the periphery, you're only looking for what says free T4, free T3. That's the only ones that really give you a good idea of what's going on with the thyroid, not the total T4. The total T4 will change depending on the albumin in the body. For example, if a patient has nephrotic syndrome, your total T4 will go down because you're losing albumin. But your free T4 is normal and your TSH is normal because the feedback is through the free T4, right? So that's why we only ask for the free T4. If a patient is pregnant or is taking estrogen, then your total albumin and your total protein in the body goes up. And so does your total T4. But your free T4 is normal, and so is your TSH. So please be careful when you're asking for, and this is in clinical practice also, when you're asking for thyroid hormones, what you're asking for, make sure you're checking off free T4, free T3. You don't want to know total T4. That could be misleading. You don't want to know T3, total T3. That's also misleading. The best initial test to do in patients with undiagnosed thyroid disease, if you're looking for thyroid disease, is a TSH. The TSH is the most important test to do in people when you're looking for thyroid disease. The new types of TSH, the third and the fourth generation of TSHs, are very sensitive and they're very specific, and they could document both hyper and hypothyroidism with a 95% confidence interval. Very important test. If the thyroid stimulating hormone level, the TSH, is normal, that patient is euthyroid. So I'm going to say it again. If you check a TSH and the TSH is normal, that patient is euthyroid. I don't care what clinical symptoms this patient has. So that's the first test you look at. And then you look at the free T4 and the free T3 to make the right diagnosis. Another test that we do is sometimes we measure this thing called the thyroid binding globulin. Here it is. And we don't always do that, the thyroid binding globulin, but I just told you before that that's co-secreted along with T4 and T3 in a 1-to-1 ratio. So if a patient's taking endogenous T4, if the patient has a high level of endogenous T4, then their thyroid binding globulin should be elevated. If a patient's taking exogenous T4, then that T4 level may be elevated, but the thyroid globulin level would be low. This is very important when we follow patients with cancer. We want to know if after thyroid cancer surgery, if any thyroid tissue was left in the body. So we go back and we measure thyroid binding globulin. If we find positive thyroid binding globulin levels elevated, that means that there's some residual tissue and the surgeon has to go back in and remove it, or they'll get thyroid cancer again. Patients that we think are taking exogenous thyroid hormones, this is common in people that are trying to lose weight. They take thyroid hormones, and what happens is they present sometimes with hyperthyroidism to the physician, and the physician thinks they have Graves' disease or toxic nodular goiter or something like that. And once they check the thyroid binding globulin, they find that thyroid binding globulin is decreased despite high levels of T3 and T4. So thyroid binding globulin levels is a good test if we want to see if a patient's thyroid hormones level is endogenously produced and they're not exogenous. So patients that have elevated T4 that's endogenous should have at the same time elevated thyroid binding globulin levels. The main secretory hormone we talked about is T4. We said T3 is more potent, and the free hormones are the only active ones, and these are the only ones that we look for. The free T4 and the free T3. TSH, I said, is the best initial test for the diagnosis. Please remember this. It's a very good test to start off in the diagnosis of thyroid diseases. And then we talked about the thyroglobulin levels. I told you if you want to know, if you want to answer the question, is this thyroid hormone endogenous? Then check the thyroglobulin level. That should be elevated also if it's only endogenous. And then there's two other tests, the antimicrosomal antibodies that we check in some patients, like Hashimoto's thyroiditis. We check for other antibodies also, thyroid stimulating immunoglobulins and stuff like that. So antibodies are sometimes some additional tests that we do for thyroid function, and we'll talk about this when we talk about this different diseases, but they're not the everyday tests that we do. We only do them in certain scenarios. And then we want to also talk a little bit about the total T4 or total T3 levels, and they're not accurate. And I told you this because you increase your albumin and your protein and your thyroid binding globulin, and because your total T4 increases in this case, because remember, total T4 is T4 plus albumin plus protein, it's increased in any case where protein and increased thyroglobulin levels are elevated, as in pregnancy and oral contraceptives, and it's decreased where we see thyroid binding globulin levels where they're decreased, like in nephrotic syndrome and liver disease. So the total T4 and the total T3 are misleading. They could fluctuate with total amount of protein in the bodies, so we don't want to look at that. The last test I want to talk to you about after the TSH, the free T4 levels, the thyroglobulin levels that we may get sometimes, is this thing called the radioactive iodine uptake test. Now, the radioactive iodine uptake test is a great test if you want to see directly the functional status of the thyroid. Because remember, when we measure free T4 and free T3 and TSH, this is an indirect way of really looking at thyroid disease. So for example, somebody comes in to me with hyperthyroid symptoms, right? I want to know, I think this patient has hyperthyroidism. I check a TSH, it's low. If free T4, it's elevated. So this tells me this patient has likely primary hyperthyroidism. But this is an indirect way of looking at thyroid disease. If I wanted to look directly at the metabolic activity of the thyroid, what do? I do this thing called the radioactive iodine uptake scan. I give the patient radioactive iodine. Remember, all the iodine in the body, well, 97% of it goes into the thyroid. So I know how much I gave to the patient, and then 24 and 48 hours later, I do this radionuclide scan where I take a picture of the thyroid, and look at this. This tells me that this patient has diffused increased uptake, because I know exactly what the parameters are. This patient should have anywhere from 5 to 40% uptake within 24 hours. Anything above that, the patient has hyperthyroidism. Anything below that, the patient has hypothyroidism. So these tests, the radioactive iodine uptake scan, is a very important test. If I want to look directly at the activity of the thyroid, we don't have to do the radioactive iodine uptake scan in all patients with thyroid disease, but we do it in those patients, especially with hyperthyroidism, that we question the diagnosis. We don't know if it's Graves' disease or subacute thyroiditis, and we do this radioactive iodine nuclear scan to look for the different types of diseases. So let's go on and do a couple of these problems with thyroid hormones to understand a couple of the concepts that we just talked about. I just want to go over this. We talked about the basic tests, and I said the TSH and the free T4 are the basic tests. And then sometimes we have to do a couple more tests to diagnose what kind of thyroid disease the patient has. We don't always have to go to further tests, but sometimes we do. One of the most common other tests that we do is the radioactive iodine uptake scan. And let's take a look at a couple of these problems. So case number 1 here, this patient comes in with a low TSH and the free T4, I'm sorry, this says T4, but they mean free T4 is elevated and the free T3 is elevated. And we don't always have to check free T3, but they're trying to tell you that both of these are elevated. So this patient came in with hyperthyroid symptoms. The TSH is low, so the patient has primary hyperthyroidism, and we do a radioactive iodine uptake scan, and it's elevated in this patient. It's increased. So that confirms the diagnosis of primary hyperthyroidism. Now, if they tell you that radioactive iodine uptake scan, it has diffuse uptake throughout the whole thyroid, then they likely are talking about Graves' disease. If they tell you that there's a solitary uptake or 2 uptakes in the gland, they're talking about toxic nodular goiter, a different type of primary hyperthyroidism. So the diagnosis here in patient number 1 would be primary hyperthyroidism right here, and either Graves' disease or toxic nodular goiter, whatever they give you a description of on the radioactive iodine uptake scan. The second case is even more interesting because look at this. This patient has an elevated T4 and an elevated T3. Now that's exactly how the prior patient presented. The TSH is decreased. Now this patient presented exactly the same way, but the reason that you thought of doing the radioactive iodine uptake scan is because you noticed in this patient that he or she didn't fit the typical patient with hyperthyroidism. They didn't have the exophthalmos, the proptosis. They didn't have the diffused big thyroid on the exam. They didn't have the lumpy, bumpy thyroid that we usually see with toxic nodular goiter. But what they had on the exam is that they had symptoms about a couple of weeks, and then when you touch their thyroid gland, the thyroid was very sensitive. And you do the radioactive iodine uptake scan in this patient, and lo and behold here, look, this patient has decreased uptake on the radioactive iodine uptake scan. And you say, how could this happen? How can the patient have increased symptoms, it's typical of hyperthyroidism, and a decreased radioactive iodine uptake scan? And the answer is this patient has subacute thyroiditis, this thyroiditis where you get a viral infection and then the thyroid is inflamed and there's breakdown of cells, spilling of the thyroid hormones and hyperthyroidism. But when you do the radioactive iodine uptake scan, there's decreased uptake. The reason is because the cells are inflamed and damaged. And this is a very important entity to know about because what happens is 2-3 weeks later, 1 month later, this patient becomes euthyroid. This disease goes away. So case number two, the typical case here, diagnosis would be subacute or de Quervain's thyroiditis. We'll talk about this disease later. So you see how you use the radioactive iodine uptake scan in a patient with hyperthyroidism to tell the difference between thyroiditis and primary hyperthyroidism. Right here, very important. That's the typical case that we use the radioactive iodine uptake scan. Now, somebody had told me one time, could this be a patient with exogenous thyroid hormone intake? Like for example, somebody that's taken factitious thyroid hormones, factitious or exogenous to lose weight. Yes, you could also have exogenous thyroid hormone taking here. This patient would suppress the thyroid, so it wouldn't uptake a lot of radioactive iodine and would present with hyperthyroidism. So that would be also a possibility. I like that. The last case, case number 3, this patient, low TSH, low free T4 and T3, right? So that patient has secondary hypothyroidism, right? Secondary because these hormones here are decreased, right here, the T4 and T3, and the TSH is also decreased. That's from the pituitary. So this patient would have something like Sheehan syndrome or pituitary apoplexy, one of those syndromes that would be consistent with secondary hypothyroidism. And you confirm that with the radioactive iodine uptake scan, and your diagnosis here would be secondary hypothyroidism. So I want you to take especially from this slide how to use the radioactive iodine uptake to differentiate between primary hyperthyroidism and hyperthyroidism due to subacute thyroiditis. These first two cases right here, these two are very important. That's the typical case where we use the radioactive iodine uptake scan to tell us the difference between one and the other.